So this is a talk on urinary tract emergencies, and we'll cover imaging of the lower urinary tract, managing cases of urethral obstruction, including stabilisation of these patients, surgical options and principles, post-operative care and complications. And then I'll cover a little bit on lower urinary tract trauma. So just as a quick look at the anatomy. In male dogs, the urethra is relatively long, and it's divided anatomically into pelvic and penile compartments. So the pelvic compartment can then further be subdivided into pre-prostatic, which is essentially non-existent in dogs, and prostatic segments. The prostatic segment passes through the centre of the prostate gland, and the penile component begins at the ischial arch and is surrounded by the corpus spongiosum for its entire length. Histologically, the urethra is made up of three layers: the mucosa, which is formed of transitional epithelium proximally and stratified squamous epithelium distally, the submucosa, and then the muscularis, which contains smooth muscle along its entire length, and then striated muscle called the urethralis in the distal 2/3. And the innervation of the urethra is via the pelvic and hypogastric nerves, and the striated muscle is innervated by the pudendal. And the branches of the internal pudendal vessels provide blood supply. So female dogs tend to have a shorter and wider urethra, and their urethra corresponds to the pre-prostatic urethra in male dogs. The external urethral orifice is located at the urethral tubercle, which is a protuberance on the ventral wall of the vestibule. And the urethra in female dogs contains significantly more collagen and less muscle than male dogs. And smooth muscle is absent in the terminal urethra. So male cats on average have a urethra length of 8.5 to 10.5 centimetres, and they have distinct pre-prostatic urethra parts, unlike dogs. The pre-prostatic and post-prostatic urethra are approximately 2 millimeters in diameter, and they narrow distally. The penile urethra is around half the diameter of the sort of pre-penile urethra, and they have relatively long internal urethral sphincter, and the striated urethralis muscle has a short functional length. And it's thought that the higher proportion of elastic fibres versus the stratum cavernosus may contribute to urethral resistance in male cats. So female cats have a similar proportional length of the urethra to that of female dogs, but the lumen is relatively smaller, and their urethral wall contains significantly more longitudinal smooth muscle and much less striated urethral sphincter. These variations in urethral diameter and smooth muscle composition may increase urethral resistance, and it's been suggested that female cats require an active mechanism to overcome urinary continence. So imaging of the urethra is challenging. The imaging options include radiographs, including contrast studies, ultrasound and CT, and then I've put MRI in there in brackets as it is possible but very rarely performed in the veterinary industry. If you're performing radiographs, you need orthogonal views of the caudal abdomen and pelvis, and in male dogs this should include a lateral projection with legs drawn forward to enable visualization of the penile urethra. So plain radiographs may be sufficient to diagnose radiopaque calculi such as calcium oxalate and struvite, but others such as cystine and urate are difficult to detect on plain rads as they're only faintly radiopaque. If you suspect urethral trauma, plain radiography is rarely diagnostic, so you need positive contrast retrograde urethropography. And negative air contrast radiography is contraindicated if you suspect trauma, as it rarely demonstrates the location of urethral injury and may result in fatal air embolism. So positive contrast retrograde urethropography is the imaging modality of choice to evaluate urethral lesions. Positive contrast agents which can be used in the urinary tract include ionic and non-ionic water-soluble agents. Ionic iodinated agents have higher incidence of side effects, so are rarely used now, and barium is contraindicated in the urinary tract. So most commonly iohexol or Omnipaque is used. When you're looking at these images, you're looking for a filling defect or extravasation of contrast. You must make sure that you collect a urine sample if you're wanting to perform urinalysis before performing iodinated contrast studies because these agents are bacteriostatic. So to perform retrograde urethropography, the patient needs to be sedated or under general anaesthetic, and you would place a urinary catheter using routine aseptic technique and empty the bladder. You then place a balloon-tipped catheter. If this is not available, then you can use a standard urinary catheter and clamp the preputial fold using atraumatic bowel clamps to prevent leakage of the contrast medium. And the catheter is pre-filled with contrast, so usually around 3 to 5 millimeters, and injected over 5 to 10 seconds, and then a radiograph is taken. Another option in male cats is to use a 22 gauge intravenous catheter with the stylet removed. And retracting the penis caudally can be helpful if you're struggling to get the catheter in to reduce the marked change in angle between the penile and pelvic urethra. Careful application of Alice tissue forceps to the preputial reflection can achieve this. And the catheter should fit snugly to limit leakage of contrast. In females, obviously, it's more challenging. You can insert a balloon-tipped catheter into the vagina and use tongue forceps to occlude the vulval opening, minimising the leakage of contrast. In cats, the most common site of urethral injury is the junction between the pelvic and penile urethra, and this is often an iatrogenic injury following attempts to catheterize blocked patients, and they don't necessarily show any obvious clinical signs. So if you see narrowing just after the pelvic urethra, this can be an indication of stricture, but it can also be artifactual, so ideally you need to repeat the study before making this diagnosis. Complications following positive contrast studies include iatrogenic urethral rupture and urinary tract infections. So we've got two examples of positive contrast studies in cats here. The first one shows a normal cat which is having investigations into lower urinary tract disease. The second shows extravasation of the contrast agent into the surrounding tissues, confirming urethral rupture. So ultrasound can be very useful, but is dependent on how skilled you are. I'm not particularly good at ultrasound, so would rely on the medics for this, but most of us can at least look at a bladder, and then you may be able to look at the proximal abdominal urethra, perineal and penile urethras in male dogs. The problem is that you can't visualize the pelvic portion of the urethra. But this modality can detect both radiopaque and radiolucent calculi, and it can also add complementary information about urethral wall thickness and mucosal surface contour. So we use CT a lot here. CT is considered superior to radiographs because it provides more detailed anatomic information, but it's not as accurate in detecting urethral stenosis. So retrograde urethropography is still required in cases where you suspect urethral stenosis. So urethral obstruction, this is a common cause of morbidity in dogs and cats, and it's a common emergency presentation, particularly in male cats. It's very rare in queens and female dogs. And there's been significant decline in numbers of these cases over the past 20 years. Both dogs and cats with urethral obstruction will have a history of straining to pass urine, but this can be mistaken for straining to pass feces, particularly in cats. So careful questioning during history taking is essential. And it also isn't always noticed by the owners of cats if they do not use litter trays. So the presentation can be very variable, from stable patients to cardiovascular collapse due to hyperkalemia and acidosis. And the obstruction might be partial or complete. And classification is based on the cause and includes these listed. Animals with complete urethral obstruction will eventually develop hyperkalemia, acidemia, and post-renal azotemia. Renal decompensation typically develops within 24 hours, with death ensuing in 3 to 6 days if left uncorrected. Prolonged bladder distension secondary to urethral obstruction may result in loss of detrusor function, which may be permanent. And the initial management has 3 aims: to evaluate the hemodynamic status, correct any metabolic derangements, and then urinary division, preferably via standard urethral catheterization. When presented with a case of urinary obstruction, initially you want to get IV access as soon as possible and perform routine biochem, hematology and electrolytes, and then start intravenous fluid therapy. Hartmann's is more efficient at correcting metabolic derangements. Even if the patient is hyperkalemic, the use of Hartmann's is not contraindicated because the amount of potassium in Hartmann's is negligible. And it has an alkalizing effect which helps to drive potassium ions intracellularly. But physiologic saline is an option if for any reason Hartmann's isn't available. Ideally, fluids should be administered for at least 15 minutes before induction of general anaesthesia and for at least 48 hours after relief of the urethral obstruction. And patients often have increased fluid requirements because of post-obstructive diuresis, and ongoing monitoring of electrolytes and acid-base status is essential. Consider ECG monitoring in cases which are hyperkalemic or bradycardic. Hyperkalemia leads to increased cell membrane excitability of cardiac myocytes, which can lead to life-threatening cardiac arrhythmias, progressing from bradycardia to ventricular fibrillation or asystole. Experimental studies where hyperkalemia has been induced in healthy patients shows ECG abnormalities which progress, as shown in this table, but we don't tend to see these abnormalities in the clinical scenario, probably because there's concurrent biochemical abnormalities in these cases. Indications for managing hyperkalemia include significant ECG changes and a hyperkalemia over 7.5 to 8 millimoles per litre. First-line treatment is with 10% calcium gluconate administered intravenously over 5 to 10 minutes. And you need to continue monitoring the ECG trace during administration. Calcium gluconate increases the threshold for cardiac myocyte depolarization, so it acts solely as a cardioprotective agent without altering the serum potassium level, and its duration of action is 30 to 60 minutes. Other treatment options include intravenous dextrose, preferably given with regular insulin. This drives potassium intracellularly by co-transportation, and its effects last for 2 to 4 hours. Another option is sodium bicarbonate. This enables hydrogen ions to move extracellularly in exchange for potassium ions. The use of this should be limited to patients with severe acidosis, particularly those with concurrent ionized hypocalcemia. So once the patient's stable, attempts should be made to catheterize and unblock the obstruction and drain the bladder. In most cats, sedation is required to prevent patient movement and allow urethral relaxation to enable passage of the urinary catheter. In those cases which are severely collapsed, sedation may not be necessary. And in collapsed patients, urethral catheterization should be performed as quickly as possible and alongside attempts to stabilize the patient's cardiovascular system through fluid and drug therapy. If the obstruction is marked, then general anesthesia may be appropriate to give more time for catheterization to be performed. And cats have an abrupt change in angle between the penile and pelvic urethra, as you can see on this radiograph. This can make passing a catheter tricky. To make it easier, if you get a pair of Alice tissue forceps and hold the edge of the prepuce to help exteriorize the urethra and pull the penis to straighten it out. If initial attempts to pass the urinary catheter are unsuccessful, retrograde urohydropulsion should be attempted, ideally under general anaesthesia. The success of retrograde urohydropulsion can be improved by using urethral catheters of various sizes, lubricating agents, or by performing a coccygeal epidural with local anaesthetic. If you're not able to catheterize the patient, then an alternative is to perform repeated cystocentesis, or if the patient is unlikely to receive surgical treatment soon, placement of a cystotomy tube can be performed. If cystocentesis is performed, the bladder should be completely drained to reduce the risk of leakage through the puncture site. And a sample of urine should always be obtained by cystocentesis or urethral catheterization for microbial culture and susceptibility before administration of any antibiotics. So to perform a cystotomy tube, you need to perform a ventral midline coelotomy and then use a Foley or mushroom-tipped catheter placed, and this is for short-term use. So a stab incision is made in the abdomen wall in a convenient paramedian position, and a purse string suture is made in the bladder and then a small stab incision made in the middle of the purse string suture. The cystotomy tube is placed into the bladder and the purse string tightened around it. 4 sutures are then placed to pexy the bladder to the abdominal wall at 12, 3, 6 and 9 o'clock positions, and the external tube is secured to the body wall using a finger trap suture. The cystostomy tube must remain in place for at least 7 days to allow time for a secure adhesion to form between the bladder and the body wall. So the term feline lower urinary tract disease is a term which covers a wide range of disorders affecting the bladder or urethra, and it includes uroliths, bacterial infections, urethral plugs, and idiopathic disease and neoplasia. Despite the variable underlying causes, clinical signs are similar and include dysuria, stranguria, hematuria, pollakiuria, and periuria. Cats with lower urinary tract disease are at risk of developing urethral obstruction, with reported rates of being between 18 and 58% in male cats. The obstruction is most frequently caused by a urethral plug, which is made up of protein, erythrocytes, leukocytes, and crystals. And the obstruction usually occurs within the distal 1/3 of the urethra. Uroliths, neoplasia, and strictures can also result in obstruction. So urethral obstruction occurs less commonly in male dogs compared to male cats and is very rare in females. And they rarely develop clinically significant hypokalemia. And in dogs, it's most commonly secondary to uroliths, and they have a strong genetic predisposition to urolith formation. Urethral calculi most commonly obstruct either immediately caudal to the os penis or at the ischial arch. In terms of post-obstruction management, there's contrasting reports between the association of recurrence and duration of use of indwelling catheters. Some reports indicate longer indwelling catheter use is associated with lower risk of short-term recurrence, but other studies show there's no significant difference between the duration of an indwelling catheter use and recurrence of obstruction. Post-obstruction diuresis is common, and urinary output should be closely monitored. Ideally monitor every hour initially and adjust fluid therapy accordingly so that dehydration and hypovolemia do not develop, and continue to monitor potassium levels, as this can lead to hyperkalemia. These patients are often also painful, so require analgesics, including opioids, and then non-steroidals can be used once they're no longer azotemic and they're eating and drinking. Antibiotics are not routinely required unless there is evidence of bacteria or severe pyuria on urinary sediment exam, and they should be based on culture and sensitivity results. So the vast majority of calculi and plugs can be dislodged and flushed back into the bladder by retrograde urohydropulsion and then retrieved via cystotomy. But for those cases which can't, urethrotomy or urethrostomy immediately proximal to the obstruction is indicated. Obviously, these cases need to be stabilized first. So urethrostomy options, we've got perineal urethrostomy in cats and scrotal urethrostomy in dogs are the sort of first line choices. And then you can also perform transpelvic and prepubic, but the last two are generally reserved for proximal urethral trauma or cases that require revision surgery. And the surgical principles when performing urethral surgery include gentle and precise tissue handling, which is essential to prevent damage. The urethral mucosa is very thin and fragile and becomes very edematous with manipulation and increasing duration of surgery. This can then obscure identification of the tissue layers and may result in suboptimal suture placement and poor tissue apposition. Achieving uncomplicated healing with minimal fibrosis is essential to minimize the risk of stricture formation, and incisions must be midline to reduce tension and result in good apposition. Accurate apposition is achieved by appropriate bite size and placement of your sutures. The skin is much thicker than the urethral mucosa, so it's recommended to perform sutures in a two-step process, enabling more parallel bites and to reduce tension on tissues. The lower urinary tract has the ability to heal very rapidly. Factors which are essential for urethral healing include mucosal continuity and urine extravasation. If a strip of urethra remains intact and urine is diverted, the urethral mucosa will regenerate within 7 days. Factors which can delay healing include traumatized tissue, inflammation, and infection. Synthetic absorbable suture with a swaged on non-cutting needle should be used for the urethra. 1.5 metric or 1 metric sizes are usually appropriate. Urine may cause hydrolysis, accelerating the loss of tensile strength, especially if infection is present or if there is altered pH. Most synthetic absorbable sutures retain adequate strength for urethral repair, and monocryl has been shown experimentally to lose its tensile strength at a rapid rate, but we don't see this clinically. You could consider PDS in cases where you're concerned about protracted healing. Braided multifilament suture material should not be used as they harbour bacteria and have tissue drag, and they degrade rapidly in urine. So urethrotomy is a temporary opening in the urethra. The most common indication is removal of calculi which cannot be dislodged by urohydropulsion. Other indications include obstructive lesions and masses where urethrotomy is required for biopsy or excision. You should always attempt to unblock by flushing calculi back into the bladder and then perform cystotomy, as urethrotomy has a higher risk of complications. So urethrotomy can be performed in the prescrotal position in dogs, most commonly because calculi are most often found at the base of the os penis. This is the optimal location anatomically, as the urethra is most superficial here and there is less surrounding of cavernous tissue. It also means that if complications are encountered, there are options for revision surgery more proximally. Urethrotomy can be closed to heal by primary intention, or it can be left to heal by secondary intention. If performing primary closure, simple continuous or simple interrupted sutures should be used. And the reported outcomes are similar whether closing primarily or by secondary healing, but there is more hemorrhage associated with second intention healing, and patients will urinate from the surgical or urethral incision for 10 to 14 days post-op until the wound heals. There is risk of urine scalding and scrotal dermatitis, so barrier ointment such as Vaseline should be placed around but not in the urethrotomy. Perineal and prepubic urethrotomy are other options for male dogs and cats if required, but if performed in these locations, primary wound closure must be performed, as there is greater risk of hemorrhage due to the deeper location of the urethra and increased vascularity in these regions. Complications include hemorrhage, which is common and is often associated with urination. And when left to heal by second intention, it's not uncommon for the site to bleed for 5 to 7 days. Urethral stricture is uncommon and may be the result of primary disease process rather than the urethrotomy itself, but if it occurs, urethrostomy is indicated. So urethrostomy creates a permanent opening, and this is a salvage surgery, so attempts to treat underlying conditions should be attempted first. They're most commonly required in male cats, and indications include urinary obstruction, which is unrelievable, recurrent or persistent urethral obstruction with calculi or mucus plugs. Recurrent obstruction is stressful for cats and the owner and potentially life-threatening, and it can get very expensive for clients. So it's important that clients are aware that urethrostomy will not treat the underlying disorder, but it should prevent the life-threatening blockage and potentially reduce the number of veterinary visits. Penile urethral trauma, which is irreversible, is another indication, and this is quite commonly iatrogenic with repeated placement of catheters. And then urethral stricture is the final indication. So in cats, penile urethrostomy is the preferred technique, and the most common indication is recurrent urethral obstruction despite appropriate management for feline lower urinary tract disease. It involves amputation of the penis and the penile urethra. In the cat, the intrapelvic urethra is relatively wide, but the penile urethra is narrow, which is why this is the most common site for obstruction. And a PU is effectively converting the male anatomy to mimic the feline urethral anatomy. Other options include transpelvic, subpubic and prepubic. The transpelvic is particularly useful for revisions of failed perineal urethrostomies. Precise and tension-free apposition of urethral mucosa to the skin is essential to achieve primary wound healing. Traditionally, non-absorbable simple interrupted sutures were recommended for apposition of the skin and urethral mucosa, but simple continuous with absorbable sutures has been described with reportedly the same outcome. We generally use interrupted as think you've got more chance of getting correct apposition, which is essential for this surgery. So post-op care, these patients ideally shouldn't have their bladder palpated too forcefully. The use of indwelling catheters is controversial and depends on surgeon preference. Historically, it was said that this predisposed to wound breakdown and stricture, but repeated exposure of the submucosal tissues to urine may promote formation of scar tissue, reducing the elastic qualities of affected regions of the urethra. So urinary diversion, either by cystotomy tube or an indwelling urinary catheter, will minimize exposure of the healing urethra to urine, and this minimize the risk for stricture recurrence. However, the presence of an indwelling catheter can promote inflammation and ascending infection. Generally, we leave indwelling catheters in for 48 hours here. And then patients should have the shredded paper or foam litter, not wood or clay, and leave the wound alone, ideally not to clean it for 10 to 14 days, as long as the patient is avoiding a good stream of urine. There may be blood clots around the stoma, but it's rare that these will cause a true urethral obstruction. and these patients must have a buster collar on for at least 2 weeks. Possible complications are listed here, and they include stricture and subcutaneous leakage of urine, with these two being the most significant short-term complications. The most common long-term complication is bacterial urinary tract infections, which is reported to affect 17 to 57% of cats. It's thought that this is the result of urethral shortening and alterations to the urethral orifice, but a study where PU was performed in normal cats revealed no increased risk of bacterial infection, so it's possible that the UTI is part of the underlying uropathy, and that urethral alteration just increases this risk further. So stricture formation is the most common reported post-op complication, with short and reported rates are between 2 and 12%. These cases often require revision surgery, but generally they have complication-free long-term outcomes following surgical revision. And these most commonly develop secondary to excessive tension on the stoma from a failure to free the wider intrapelvic urethra from its pelvic attachments. So it's essential that you dissect the urethra to the level of the bulbourethral glands to ensure you've freed it sufficiently. If insufficient length of the urethra is available to create a tension-free urethrostomy, transpelvic urethrostomy may be indicated. And then urine extravasation typically results from imprecise urethrocutaneous apposition, and this can lead to leakage of urine into subcutaneous tissues, resulting in inflammation, fibrosis, and stricture. In severe cases, there may be tissue necrosis leading to sloughing of the perineal skin. Treatment typically warrants a period of temporary urinary diversion and open wound management before definitive revision. If you're concerned intra-op that the urethral incision is higher than normal or under tension, or where there is excessive swelling, leave an indwelling Foley catheter for 1 to 3 days post-surgery. Overall, perineal urethrostomy can provide a good long-term functional outcome in cats when performed correctly, providing that the underlying uropathy receives appropriate long-term medical management. In a recent study of 86 cats that had perineal urethrostomy and adjunctive medical therapy, 87% survived longer than 6 months post-op, and only 11% had multiple or severe recurrence of lower urinary tract disease. Owners report positive outcomes for the vast majority of patients, with 88% categorized as having good long-term quality of life. Long-term monitoring should include urinalysis, culture and sensitivity, and every 4 to 6 months in an ideal world. So urethrostomy in dogs, the ideal site is a scrotal urethrostomy. Calculi are most often found at the base of the penis, and the urethra is relatively superficial and wide at the level of the scrotum, where there's less cavernosus tissue, therefore less hemorrhage. Additionally, if complications occur, there is the option for revision surgery more proximally. Other possible locations include prescrotal, perineal, or prepubic. These variations have significant disadvantages and greater morbidity, including urine scalding, urinary tract infection, and incontinence. Prepubic has a particularly high complication rate. And you need to warn owners that their dog will need to be castrated for a scrotal urethrostomy to be performed. Urethrostomy is very rarely indicated in female dogs and cats, and it's limited to the subpubic and prepubic locations. And then post-op care following scrotal urethrostomy in dogs is very similar to cats, so we tend to leave indwelling catheters in for 24 to 48 hours to try and leave the stoma and not clean it for a good 2 weeks, and to keep the buster collar on. So the most common complication following scrotal urethrostomy is persistent hemorrhage. The most common complication post-scrotal urethrostomy is persistent hemorrhage, and bleeding is associated with urination and occurs on average for 3 to 5 days and is usually self-limiting. Hemorrhage that persists for more than 10 to 14 days post-op may require revision surgery. Intermittent urine scalding, recurrent urinary tract infections and recurrent obstruction from calculi can occur and occurred in 10% of dogs in one report. Stricture is rare and is likely the result of poor surgical technique, post-op self-trauma, or a result of the primary disease process itself. So urethral injury or trauma. The most common cause is external accidental trauma, typically blunt abdominal trauma, so most commonly road traffic accidents, particularly in dogs, or iatrogenic from repeated catheterization. Male cats are most frequently affected due to their anatomy and their roaming behaviours. And there's a high incidence of iatrogenic catheter-associated injury in male cats associated with lower urinary tract obstruction. And as I said earlier, the abrupt change in angle between the penile and pelvic urethra means that there's a risk of dorsal tearing of the urethra with improper technique. Injury to the urinary tract is easily missed at the time of presentation of trauma. Clinical signs can be vague and often overshadowed by more apparent injuries or life-threatening conditions such as hypovolemic shock or head trauma. Animals with partial urethral lacerations often appear to urinate normally, and therefore diagnosis of urethral trauma could be delayed. Despite urethral disruption, it's often possible to pass a catheter into or manually express the bladder, but if left undiagnosed or untreated, it can lead to serious morbidity and potential mortality. Outward signs may be very subtle, so early diagnosis of urethral trauma requires a higher index of suspicion. In one study, urinary tract injuries were suspected during physical examination in only a third of animals that were subsequently found to have urinary tract trauma associated with pelvic fractures. Factors which should increase your suspicion of urethral trauma include hematuria. This was the most common clinical sign in one study. Pelvic fractures or skin wounds that suggest penetrating trauma into areas overlying the urethra. Unexplained uremia in a recently injured animal, and positive contrast radiography is recommended following catheterization to confirm that the catheter has not passed through the defect into the surrounding tissues. Thorough patient assessment and careful attention to patient stabilization are essential, and diagnosis and surgical repair should be delayed until the patient is stable. Stabilization should be aimed at re-establishing tissue perfusion with fluids and oxygen delivery. So uroperitoneum develops from disruption to the urinary bladder, proximal urethra or distal ureters, and is initially a medical emergency. Many cases are not stable enough for diagnostic procedures and surgery, and need stabilization first to re-establish tissue perfusion with fluids and oxygen. It will rapidly lead to the development of uremia and hyperkalemia, so these cases need surgery to treat the primary injury and provide urinary drainage. ECG monitoring is recommended, and medical management of hyperkalemia will only provide short period of improved stability, so definitive repair or urinary diversion must be prioritized as soon as the patient is stable enough. An indwelling catheter should be placed to constantly drain urine. If this isn't possible, so for example, if the urethral rupture has occurred, then either perform repeated cystocentesis or cystotomy tube placement. If repeated cystocentesis are being performed, a definitive management plan needs to be executed within 12 to 24 hours. If it's anticipated that this will be prolonged, cystotomy tube should be placed. So to diagnose, early clinical signs include anuria, stranguria, hematuria, abdominal pain, and the presence of abdominal fluid or the lack of a palpable bladder. But the ability to urinate and the presence of a palpable bladder does not rule out urinary tract trauma. Rupture to the intrapelvic or penile urethra may not result in immediately detectable free peritoneal fluid because leaking urine will seep subcutaneously. Subcutaneous swelling and fluid accumulation should alert you to this possibility, but it's not always apparent initially and or can be misinterpreted as being related to bruising from the trauma. Urinary tract trauma often leads to postrenal azotemia. Hyperkalemia may not develop for 48 hours or more post-trauma, so cannot be relied on to detect urinary tract rupture. Ultrasound and radiographs can be useful, but an ultrasound is particularly useful, but if not available or you're not experienced, then screening rads should be used. And you're looking for evidence of abdominal fluid, which ultrasound is significantly more sensitive at detecting if there are any small volumes. If you find abdominal fluid, then tap the fluid. Uroperitoneum can be diagnosed by biochemical and cytological evaluation of the fluid. Look at the creatinine concentration. A ratio of abdominal fluid to blood over 2:1 is predictive of uroperitoneum with a specificity of 100% and sensitivity of 86%. A potassium ratio of 1.4:1 has 100% specificity and sensitivity. And the concentration of urea in abdominal fluid is not reliable because there's rapid equilibration between abdominal fluid and plasma. Cytology of the fluid is useful to establish the presence of bacteria and rule out or confirm a diagnosis of septic effusion. Positive contrast retrograde urethrophy is indicated in patients presenting with confirmed uroperitoneum and in cats with traumatic pelvic fractures or trauma to their pelvic limbs, as they are at high risk of concurrent urinary tract injury. Some studies report mortality rates of 25 to 40%, and one suggested that elevated serum creatinine at presentation was a poor prognostic factor, but generally if the underlying cause is treatable and there are no concurrent injuries, the prognosis for uroperitoneum is good. The probability of bladder trauma is directly related to the degree of distension at the time of trauma. Other causes for bladder rupture include severe cystitis, neoplasia, urethral obstruction, and iatrogenic causes. So surgical management includes midline coelotomy, isolating the bladder and assessing the viability by evaluating its colour, wall thickness and blood supply. Any necrotic areas or highly traumatized areas are trimmed with scissors. And as long as the trigone is intact, up to 75% of the bladder can be removed and will gradually regain adequate size. If resecting large portions of the bladder, closing over a small Foley catheter bulb to ensure the lumen is maintained can be useful. And generally, closing in a single layer using appositional sutures is performed, but studies show that there's no significant difference in short-term complications and duration of hospitalization when other suture patterns are used. Prognosis, if appropriately managed, is good if appropriately managed and no significant concurrent injuries are present. So urethral trauma was historically reported to be most commonly from urethral obstruction and attempted catheterization, but more recently it seems to be more commonly caused by RTAs. In dogs, RTAs are by far the most common cause, but the incidence is still relatively low, with one study showing only 2 in 600 dogs reported to have urethral disruption secondary to trauma. Urethral trauma may range from simple contusions to a tear to a partial or complete transection. In cats, location of disruption is dependent on the inciting cause. So iatrogenic disruption is typically identified in the post-pelvic urethra, whereas external trauma more likely results in disruption of the intrapelvic urethra. Iatrogenic trauma typically occurs at the dorsal aspect, where the penile urethra transitions into the pelvic urethra. To avoid the sufficient sedation and caudal retraction of the penis during catheter placement to efface this flexure should be performed. Urethral trauma may result in bruising, rupture, avulsion, and post-traumatic scarring. And distal urethral disruption is more likely to result in subcutaneous urine leakage. Accumulation of urine within subcutaneous tissues results in extensive cellulitis and tissue necrosis, typically seen as bruising, but ultimately results in the formation of a urethro-cutaneous fistula or necrosis and sloughing of the overlying skin. Urine may leak and accumulate in the abdomen, pelvic canal, or subcutaneous tissues, leading to tissue necrosis. And this usually becomes apparent after 24 to 48 hours, but the true extent of tissue necrosis may not be apparent until 10 days to 3 weeks later. Complications of urethral trauma include stricture, ongoing urine leakage, and urinary incontinence or UTI. So the treatment for urethral trauma depends on the location. We've got 3 options, so we can temporarily divert urine and then primarily repair the trauma, temporarily divert urine and leave the lesion to heal by secondary intention, or permanently divert the urine by urethrostomy. Urethral mucosa will regenerate over a catheter if a viable strip of tissue bridges the defect, so conservative management and second intention healing can be considered in these cases, which would involve simple urinary diversion. If this isn't performed early, there's a risk that the urethral mucosa will retract and fibrotic tissue will bridge the gap, resulting in obstruction of the urethral lumen. Smaller lacerations will usually heal spontaneously if urine is diverted for around 7 days. Larger defects may require catheterization for up to 4 weeks to completely heal. If completely severed, an end-to-end anastomosis needs to be performed with full thickness, simple interrupted absorbable suture, placing a catheter to suture over and keep in post-op for urinary diversion. Primary anastomosis carries a reasonable risk of stricture, so urethrostomy may be a more suitable option in certain cases. And be aware that pubic osteotomy may be required for access. Often injuries to the pelvic urethra require urethral anastomosis with indwelling catheters or cystotomy tube for urinary diversion post-op. This reduces tissue irritation and potentially reduces urethral stricture, which is associated with urinary contact with the healing incision. In a case series of 63 cats with urethral disruption, 75% survived to discharge. Cats with iatrogenic injury were more likely to survive to discharge and have a good outcome compared to those who suffered traumatic injuries. In dogs, the presence of multiple concurrent traumatic injury was the only significant factor associated with poor outcome, but the prognosis following urethral resection and anastomosis is guarded because there will always be some degree of luminal stenosis.